This is Chapter 30, Pain Assessment and Management in Children. Your objectives for this chapter are to identify measures to assess pain in children, list various types of pain assessment tools for use in children, outline essential pain management strategies to reduce pain in children, review common types of pain experienced by children, and discuss evidence to support specific pain management strategies. There is nurse's assessment of pain, or NAPI, that's done for the newborn to 16 years. There's a behavioral pain score for ages 3 months to 36 months. Modified behavioral pain scale 4 to 6 months. Objective pain score 4 months to 18 years. These are all in your book. The intensity of the pain needs to be measured. Satisfaction with treatment. If the treatment is not working, then you need to change the treatment. Symptoms and adverse events, physical recovery, and emotional response. Obviously, this infant appears to be in pain. A few years back, the neonatologist in the NICUs did not believe that infants felt pain. We've since proved them different. See box 30.1 on page 95. And you can see here that this baby has pain reflected after a heel stick with the eye squeeze, brow bulge, nasolabial furrow, and a widespread mouth. This is just a list of some of the behavioral pain measures from table 30.1 and 30.2 in your book. Self-reporting pain rating scales measures are most often used for children older than 4 years old. Complex regional pain syndrome and chronic daily headache are the most common types of chronic pain in children. Several cognitive skills such as measurement, classification, and seriation, which is the ability to accurately place in ascending or descending order, become apparent between 7 and 10 years of age. Older children are able to use the 0 to 10 NRS score used by adolescents and adults. Emotional and social and school functioning may have an influence on how a child responds to pain. This is your adolescent pediatric pain tool. The patient is asked to color in where it hurts, and this is used a lot with sickle cell patients. The impact of early pain exposure greatly affects the developing nervous system with persistent long-term effects. This makes the neonatal assessment extremely important, although difficult, because the most reliable indicator of pain is self-reporting is not possible. Evaluation of the infant must be based on physiological and on your behavioral changes with validated instruments. Vocalization, facial expressions, body movements, and vital signs may be indications of pain. And you can see table 30.3 on page 799 for more about this. The revised FLACC for communication and cognitively impaired children is now called the Non-Communicating Children's Pain Checklist, or NCCPC. This is a measurement tool specifically for children with cognitive impairments. See page 801 to 802. Also need to look at the cultural considerations box for pain scales on page 800. And for children with chronic illness and complex pain rating, this pain is only one aspect of assessment and does not always accurately convey to others how they really feel. The most important aspect of a pain assessment for children with chronic illness, particularly those with complex pain, is the relationship that develops between the child and the family. This pain assessment checklist can be seen on page 801 and 802. Pain is often associated with stress, fear, and anxiety. This list tells you some of the ways to help without using medication. Children can be easily distracted. You can help them to relax using guided imagery, cutaneous stimulation by simply rubbing your fingers lightly over their skin, on their arms, their backs, or their foreheads. Containment and swaddling can be done with infants and babies. Non-nutritive sucking, as in using a pacifier, and kangaroo care, which we all know is skin-to-skin contact. Use a heel warmer properly designed to place on the infant's skin to prepare for a heel stick. Never, ever warm a wet diaper in the microwave and place it on the skin of an infant or anyone else, because this is what will happen. A nurse in Texas got a diaper and filled it with water and put it in the microwave and then applied it to the baby's ankle and foot, which then caused second-degree and severe second-degree burns. This nurse lost her license, there was a lawsuit, and the baby even lost a toe because of this nurse who'd been practicing for more than 30 years. I don't know why she thought that was a good idea. This is an example of kangaroo care or skin-to-skin contact. The mother seems very comfortable and very happy, and the baby seems pretty comfortable too. And this little tiny baby is on a ventilator. Biologically based foods or plant supplements, chiropractic, osteopathy, massage, Reiki, bioelectric or magnetic treatment, pulsed fields like in using a TENS unit, alternating and direct currents, mental healing, expressive treatment, spiritual healing, hypnosis, relaxation, homeopathy, naturopathy, acupuncture, and moxibustion are all examples of complementary and alternative medicines, or CAMs. Some of your pharmacologic managements you can see on table 30.4, page 805, for NSAIDs for children. Please note in that box or that table that acetaminophen is listed here. Morphine is the next choice if NSAIDs do not work, although other opioids may be considered, like fentanyl over morphine. The co-analgesics may be used with opioids or alone. See page 807, box 30.8. The right timing for medication depends on the type of pain the child is having. Cancer patients may be on pain meds around the clock, but others may only need it whenever they need it. This is a nurse programming a PCA pump. Look on page 813, box 30.4 for more about the PCA pump. Other ways to handle pain management pharmacologically is your epidural analgesia, transmucosal and transdermal analgesia. Monitoring side effects is super important. Evaluation and effectiveness of the pain regimen. Consequences of untreated pain in infants. You can have physiologic indicators and behavioral indicators. This little girl here has learned about what we call the EMLA cream. She seems very pleased with that. It is an anesthetic cream, and there's also one called LMX that can be applied 60 minutes in advance of starting an IV, when time allows, or drawing blood work, again when time allows. And you can see about these on page 812 in your book. Common pain sites, painful invasive procedures, postoperative pain, and burn pain. Burn pain is one of the hardest pains to manage because every time they move, change position in the bed, walk, or sometimes even breathe, they have pain. Dressing changes and debridement require medication. At least 30 minutes in advance of the whirlpool dressing change, and they still have pain. For recurrent headaches, we need to modify behaviors and recognize the triggers that cause them. Recurrent abdominal pain is defined as pain that occurs at least once a month for 3 consecutive months, accompanied by pain-free periods, and is severe enough that it interferes with the child's normal activities. A multidisciplinary approach to pain of a sickle cell patient is necessary. Both pharmacologic and non-pharmacologic treatment is needed. The non-pharmacologic things needed would be like cognitive behavioral intervention, heat massage, and physical therapy. Many of these patients have pain crisis and end up in the ER and then admitted for IV pain therapy at very high doses. Over time, they build up a tolerance to the morphine, and so a different drug may be tried or a combination of 2 or more drugs. See page 813, Community Focus. The focus box is on fear of opioid addiction. Pain in children with cancer may be related to an operation, mucositis, a phantom limb, or infection. Pain after bone marrow transplant is also common. And your question for this chapter is, which of the following is an important factor for consideration in understanding the pain experience in children? A, children cannot tell where they hurt. B, children may not admit having pain. C, narcotics are dangerous drugs for children. Or D, children's sensitivity to pain is less than that of adults. I'll give you a minute to think about this. But I will tell you that the correct answer is B. Children may not admit having pain because they know if they tell you they're in pain, then you're going to take them to the doctor and they might get a shot or have to have blood drawn. So it's out of fear that they're not telling you they're in pain. Good parents will be able to recognize when there's something wrong with their children. They don't have to tell you. This concludes this chapter's PowerPoint. Thank you.